In this lecture, we will be covering the anatomy that is above the brainstem and underneath the cerebral cortex. So this is subcortical central nervous system, and we'll be talking about diencephalic structures, the basal ganglia, and white matter. So remember, when we use the term diencephalon embryologically, that this includes anything with the word thalamus in it. So the largest component is the thalamus, which we can see right here. And remember from our lecture just recently that the anatomically, if we're looking for the boundaries of the thalamus, medially we have the third ventricle, and laterally we have the posterior limb of the internal capsule. Okay, so we have the large thalamus there with many subnuclei, which we're going to go through. So here's the right and left thalamus, and we can see that the thalamus has many different nuclear groups here. The internal medullary lamina show up well in this slide, and we can see these kind of subdivide, separate the different thalamic nuclei, and we'll see there's even a thalamic nucleus located within the internal medullary lamina. Not really shown here is around the thalamus we have the external medullary lamina, and as we'll discuss, that has an important function. So we'll kind of go through these a little bit by subdivisions here. We'll start with the anterior nucleus, then we'll talk about the medial thalamic nuclei and the lateral thalamic nuclei. All right, so the anterior thalamic nucleus we've discussed before. In fact, most of these thalamic nuclei, with a few exceptions, have come up previously. And the anterior thalamic nuclei is part of the Papes circuit. Remember this Papes racing circuit, which from the mammillary bodies goes up to the cingulate gyrus through the thalamus, and more specifically through the anterior nucleus of the thalamus. So here's a more detailed drawing by a student that just graduated here recently. So if we follow here the pathway from the hippocampus around to the mammillary bodies, okay, from here it goes up via the mammillothalamic tract to the anterior nucleus of the thalamus, and then from there we have these projections up to the cingulate gyrus, and then that goes back down to the hippocampus. When we talk about memory, how memory works, in a lecture that's coming up soon, we'll explain this in a little more detail, but the anterior thalamic nucleus is a part of that circuitry, so there is an important function there in terms of memory, laying down new memories. Now, closely related, actually, is the medial thalamic nucleus, the dorsal medial nucleus. And this provides a relay between the amygdala and the medial prefrontal cortex and the ventral medial prefrontal cortex here. And so remember, the amygdala is part of the limbic system, and so we want to think of the dorsal medial nucleus as part of the limbic system, and actually the hippocampus is part of the limbic system also. So both of these first two thalamic nuclei are related to the limbic system. It's always dangerous to summarize this in one word, but I think motivation would be, maybe if I had to just sum it up to one word here, in terms of the dorsal medial nucleus and its function relaying information from the amygdala to the medial prefrontal cortex here. Okay, so we've talked about the anterior thalamic nucleus and the dorsal medial nucleus, which is here. So again, this is going to the prefrontal cortex, and this is part of Papes' circuit. So now we'll move out into the lateral thalamic nuclei, and we'll start back here. Now this is new information. The pulvinar is a very large thalamic nucleus, and it kind of works together, same function essentially as the lateral posterior nucleus right here. All right, so both of these, the pulvinar and the lateral posterior nucleus of the thalamus, have to do with vision, but not visual acuity, In fact, this is called an extrageniculate visual pathway because the lateral geniculate has to do with visual acuity. This has more to do with tracking things in space. And so this is actually a relay nucleus. The pulvinar is, and the lateral posterior, from the superior colliculus to the visual association cortex. So we've mentioned the superior colliculus as an important nucleus for vision several times, and it works together with the pulvinar to help guide eye tracking movements and also just the ability to quickly localize something in space, which is a very remarkable, complex process, and I think that's why the pulvinar is so large. There's a lot involved in the ability to do that. Okay, also out here in the lateral thalamic nuclei, we have the ventral anterior, ventral lateral, and then VPL and VPM. Okay, so in terms of basal ganglia circuitry, which will be the end of this lecture, the ventral anterior nucleus of the thalamus is the most important in terms of the basal ganglia communicating with the motor cortex, the prefrontal cortex here. For the cerebellum, we said last time that the ventrolateral is the most important thalamic nucleus as it relates to the cerebellum. So those projections that go from the cerebellum up to the motor cortex relay through the ventrolateral thalamic nucleus. VPL, we've mentioned probably a dozen times in the brainstem lecture that vibration, proprioception in the medial lemniscus, pain and temperature in the spinal thalamic tract, that these are traveling together, headed up to the VPL of the thalamus, and then finally onto the post-central gyrus. Okay, and right adjacent to VPL, we have VPM, which is sensation for the face. So, arms and legs, VPL. Face, VPM, and also gustatory information works its way up to the also to the post-central gyrus via the VPM of the thalamus. All right, so kind of a busy slide here, but there's really just one point that I wanted to make from this. We've spent a long time in the brainstem talking about the different trigeminal nuclei. We have the spinal trigeminal nucleus and tract. Remember, that's involved in lateral medullary syndrome. Here's the motor trigeminal nucleus and the main or principal trigeminal nucleus. Here's the mesencephalic trigeminal nucleus. So we went through all the different function. But what I mainly want to point out here is that sensation on the face, just like sensation in the arms and legs, I mean, just like pain and temperature in the spinal cord, it crosses over. Okay, and really the only reason I'm bringing this up is in just a minute we're going to talk about what happens when someone has a stroke in the thalamus. And I'll tell you that the patient has a loss of sensation on the opposite side of the body, face, arm, and leg. And so I think you would easily understand that the opposite arm and leg are involved because we've been over the medial lemniscus spinal thalamic tract so many times. But I hadn't really emphasized that this sensory information here for the spinal trigeminal nucleus and the chief trigeminal nucleus, this also crosses over. So if we have a lesion in the thalamus, it's going to cause a loss of sensation in the opposite face, arm, and leg. Okay, so VPL, VPN, arm and leg, and face. Now, I won't ask you this, but there's also a ventral posterior inferior, and this is how vestibular information gets up to the brain, but I think that's a small detail for now. Okay, so one thing clinically now I'll tell you about the thalamus is if we do have a stroke in the thalamus, which we can see right here, that is going to cause a loss of sensation on the opposite side of the body, as I just said. The blood vessel that supplies the thalamus is the thalamo-geniculate artery. So if that blood vessel gets occluded, which often happens in patients that have diabetes and chronic hypertension, then the patient will present with sensory complaints on the opposite side of the body. And so an interesting thing happens here in a thalamic stroke, and that is this is often painful on the opposite side of the body. Patients will describe an uncomfortable burning sensation, an uncomfortable tingling sensation in the opposite face, arm, and leg. And that is known as the thalamic pain syndrome. But if you had to say which nuclei are involved in thalamic pain syndrome, you would choose VPL for the opposite arm and leg, VPM for the opposite side of the face. Okay, next the lateral geniculate and the medial geniculate. So remember for vision, as we have vision coming through the optic nerve, optic chiasm, optic tract, the synapse occurs here in the lateral geniculate nucleus, and then that relays vision back to the occipital cortex. All right, so that's the function of the lateral geniculate. This is enormously complex. One of our recent neurology residents did research for 5 years on the lateral geniculate, very detailed kind of understanding how it helps to actually filter out unnecessary vision. I mean, we can't take in all of the vision around us every millisecond. And so there's a lot going on here in the lateral geniculate, but I'm not going to go into that. This would be one of the highest yield thalamic nuclei to remember, certainly for boards. The medial geniculate is just medial to the lateral geniculate. Okay, and this slide is also nice because it shows the connections between the superior colliculus here and the pulvinar. Okay, so remember that is vision, but more with tracking and object localization. So the lateral geniculate is for visual acuity. When you're reading, for example, then you're really utilizing this pathway here through the lateral geniculate. All right, the medial geniculate has to do with sound. Sorry, not the best quality slide here, but as sound comes into the brainstem, and we've talked about the cochlear nuclei, the superior olivary nucleus, remember for sound localization, and how this crosses back and forth, not shown here, but this is the lateral lemniscus, and then synapsing on the inferior colliculus, and then the medial geniculate, and then up to Heschel's gyrus here on the temporal lobe auditory cortex. Okay, so medial geniculate is for sound. And so remember the lateral geniculate has that distinctive Napoleon's hat shape. Okay, so that should always be a giveaway there. The medial geniculate is, if you see a nucleus medial to it, it's the medial geniculate. Never stands out as much, but that is the medial geniculate for auditory information. Okay, so we've covered most of these nuclei. Now let's just talk about what is happening here around the thalamus. Okay, and this is this external medullary lamina. And so it turns out that, that this external medullary lamina is loaded with GABA. It's GABAergic, so it's inhibitory. And this is when we call the thalamus the executive secretary, sort of determining, do you want to get all sensory information bombarded, like you're woken up at 2 in the morning and you want to get all the vision and the sound and everything, and then the GABA would not be very active and you would be flooded with sensory information. Or if you're in a zone studying and you want to just tune everything out, then the GABA would be very active, so that you're not, thinking about all that sensory input. So that appears to be the function of the external medullary lamina, to sort of appropriately inhibit areas that aren't needed as much. This is the only thalamic nucleus that doesn't project to the cerebral cortex. It has a local effect, shutting down specific areas of the thalamus. Okay, so the intramedullary lamina, there are these nuclei in here, and there's only one that you need to know, and that is the centromedian nucleus, CM. Okay, and this is a very important thalamic nucleus for pain information. So there are these pain pathways that ascend from the spinal cord. I'll just mention one, the spino-reticular tract, which I didn't talk about in the spinal cord lecture because we're going to bring this up in the pain lecture. And this carries often more kind of a chronic, painful information up to the reticular formation in the brainstem, and then to the centromedian nucleus. And unlike all of the other thalamic nuclei that we've talked about, this goes to widespread, non-specific areas of the cerebral cortex. Okay, and we'll see in basal ganglia circuitry, it's also involved there as well. But I really want to emphasize here to associate this nucleus with ascending pain information. So here's pain coming up. Let's say this is the spinal reticular tract going up to the reticular formation. And notice what pain does, especially chronic pain. It's really activating for the entire brain. And this is unique compared to all of the other thalamic nuclei, like lateral geniculate. It has a point-to-point relationship with the occipital lobe for vision. Medial geniculate, point for point for auditory information. Pain via the centromedian nucleus kind of just has an effect on the entire brain. So here's a summary in your handout of all of the thalamic nuclei. I would say in terms of which ones would be most likely asked on boards, certainly VPL, VPM, and lateral geniculate. I think those would be the three highest yields in terms of a national board type question. Now the epithalamus includes the pineal gland back here. When we have our lecture on sleep, I will tell you about melatonin production and how that relates to sleep. And we did discuss in our lecture on the midbrain a pinealoma and how that can compress on the dorsum of the midbrain. Here's the superior colliculus, how that affects vertical eye movements, that it can cause a non-communicating hydrocephalus by occluding the cerebral aqueduct. But I won't say more about that for now. Also, we're not going to talk about the hypothalamus in this lecture because we have an hour lecture on all of the nuclei and the function of the hypothalamus. So next, let's talk about white matter. And really, I'm only going to emphasize a couple of things. The main focus will be that you get down exactly what is in the internal capsule. I think that has the highest clinical relevance. So we'll be going over what's in the posterior limb, genu, and anterior limb. Okay, we've done this before, but now you know more, and so we can add a little more clinical information to this. Remember that lateral to the internal capsule, we have the putamen. Here we can see a little bit of the globus pallidus right there. And medial to the anterior limb, we have the caudate, because in just a minute we're going to go over basal ganglia circuitry. And remember that the caudate and the putamen together we call the striatum. All right, so a drawing that you've seen before, but let's spend a little more time on this now. So here we can see the lateral geniculate conveying vision back to the occipital lobe, the medial geniculate conveying sound to Heschel's gyrus out in the temporal lobe. Okay, and now we have our internal capsule. So in the posterior limb, there are two main pathways. The corticospinal tract, we mentioned several times, and the superior thalamic radiations. And I just realized this could be a bit confusing. The arrow here is just to identify this pathway, not to indicate that it's going down. This is actually all of the sensory information from the arm and leg via the medial lemniscus, spinal thalamic tract, synapses in VPL of the thalamus, and then it gets up to the postcentral gyrus here through the superior thalamic radiations. Sensation for the face would travel through here as well. So significantly here, the posterior limb of the internal capsule contains the ascending sensory fibers for the opposite face, arm, and leg, and it conveys the descending motor pathway for the opposite arm and leg. Okay, and then if we lump in the cortical bulbar tract here, this is supplying the motor nuclei in the brainstem. So sensory are right adjacent to motor. In the anterior limb of the internal capsule, we have the cortical pontocerebellar tract, that pathway that is going down to the pontine nuclei and then to the cerebellum. Okay, cortical pontocerebellar tract is kind of scattered around. There is even some in the posterior limb, but let's forget that and just put it mainly here in the anterior limb of the internal capsule. The anterior thalamic radiations, this is part of Pape's circuit, that connection between the anterior nucleus of the thalamus going up to the cingulate gyrus. Travels right here in the anterior limb. And then finally, the pathway from the frontal eye fields that is involved in coordinating eye movements is right here. So when we use the term cortical bulbar tract, we're talking about upper motor neurons that control the pons and the medulla. The pathway here for the frontal eye fields, this is targeted really to the areas in the brainstem that move your eyes. And so they're right adjacent to each other. Okay, so let's make some clinical applications. First of all, notice we have the middle cerebral artery here going through the Sylvian fissure, supplying the lateral hemisphere of the brain. And off of the middle cerebral artery, we've mentioned that there are these penetrating branches, the lenticulostriate arteries. And these arteries supply the motor fibers in the posterior limb of the internal capsule and also in the genu. And so the lenticulostriate branches supply the cortical spinal tract and the cortical bulbar tract. And so if we have an occlusion of a lenticulostriate artery, we affect these two pathways, which notice are motor. And this actually turns out to be the most common stroke syndrome that we see. Most medical students, even if you just do 2 weeks of inpatient neurology, you're going to see this stroke. It's that common. And it's called a pure motor stroke because the patient comes in with weakness in the opposite lower face, arm, and leg. And they have nothing else. They just have weakness. They don't have visual loss, sensory loss, anything else. They just purely have weakness. And so pure motor stroke always localizes to, usually we say the posterior limb of the internal capsule, but it's also the genu that affects the face. Okay, so you need to know where the lesion is. It's right here, posterior limb and genu, and also the blood vessel, lenticulostriate. All right, and I'm sorry, this is the best picture of this that I can find, but so here's the middle cerebral artery, here are the lenticulostriate branches. This is the posterior cerebral artery coming off of the basilar here, and so off of the posterior cerebral artery we have penetrating branches that supply the thalamus, and those branches are called the thalamogeniculate arteries. It's supplying the thalamus, and if we have occlusion here, that will cause a stroke in the thalamus. Okay, and so the patient usually presents with pure sensory loss on the opposite face, arm, and leg. So this is known as a pure sensory stroke. And again, if you had to say which thalamic nuclei are involved, it's VPL for the arm and leg, VPM for the face. So it's very significant here that a pure motor stroke comes off the middle cerebral artery, so this is anterior circulation, whereas the pure sensory stroke comes off the basilar artery, the posterior cerebral, and is posterior circulation. Okay, so just as an example, if someone has a pure motor stroke, well, that could relate to carotid artery disease. More likely it's occlusion of these small penetrating blood vessels. But if someone has a pure sensory stroke, you know this is posterior circulation, not coming from the carotids, but from the basilar artery, posterior cerebral. Okay, so the point is here, even though these pathways are so close together, sensory and motor, their vascular supply is different, and so it produces two very different stroke syndromes. Okay, and I think we have talked enough about the cortical bulbar tract. I've shown you this slide several times, and we've emphasized an upper versus a lower motor neuron facial weakness several times, but I do want to now add one additional syndrome that you haven't heard about yet, at least from me, and that is called pseudobulbar palsy. And if you hear the term pseudobulbar palsy, the pathway you want to associate with that is the cortical bulbar tract. And pseudobulbar palsy occurs from many lesions in the subcortical white matter. These can be strokes or any variety of different conditions. And what happens is these lesions just chip away at the cortical bulbar tract. And so eventually you have a disconnect between the motor cortex and the brainstem. Okay? And so if we just go back here and think about, okay, well, what does the cortical bulbar tract do? Well, it supplies the nucleus ambiguus. And so not surprisingly, a major feature of many, many lesions on both sides of the cortical bulbar tract is patients have significant dysarthria, dysphagia. Also disconnecting with the hypoglossal nucleus that affects the tongue. That'll cause dysarthria and dysphagia. So these are major features of pseudobulbar palsy, dysarthria, dysphagia. Now, just because of the burden of disease here, if you knock out this many circuits, that's going to have a cognitive function. So these patients often have some degree of dementia. And if you have this many lesions, those are going to affect other motor pathways, visual pathways. So the patient is going to have some focal findings on exam, a hemiplegia, visual loss, something like that. And then finally, maybe not intuitive here, but if you lose a lot of the cortical bulbar tract, this can result in what is known as emotional incontinence. Not the most flattering term here, but this describes basically patients that can't control their emotions. This often happens watching TV. It's something not that funny or not that sad, and the patient can't control either giggling or crying uncontrollably. Tends to be more on the crying side of things. So when I talk with patients that have a new pseudobulbar palsy and they're describing what's going on, often they'll just keep crying as you're trying to take the history. And I should mention that ask a patient, are you feeling really sad? And usually they will say, no, it's just like a reflex. I can't control it. I don't feel that sad, but yet I weep uncontrollably. The classic condition that involves subcortical white matter is multiple sclerosis. And we have a whole hour lecture on multiple sclerosis, so we'll go into this a lot. But I just want to kind of tie this together. As long as we're talking about subcortical white matter, we can see these lesions here in multiple sclerosis as our classic example of a central nervous system demyelinating disease. And I also want to remind you that the optic nerves are central nervous system pathways. They're myelinated by oligodendrocytes, so those are also involved in multiple sclerosis. All right, so one other condition that occurs if we have a lesion of the anterior portion of the corpus callosum. This can result in a focal apraxia. And so honestly, I try not to teach to the boards too much, but this was, a medical student told me this was a board question, which I was quite honestly surprised because years ago I was at some neurology meetings in San Diego, and they had one of these clicker sessions to find out who is the smartest neurologist, and this was a stump question for neurologists. So I was very surprised they would ask this of a medical student board exam. But here's how this works, and forgive the drawing here. This is one that I created just to try to illustrate this. So I'm assuming here that here in the left hemisphere that we're dealing with someone who's right-handed and their left hemisphere language dominant. All right, so let's just say that we have someone with a lesion of the anterior portion of the corpus callosum, and you ask that individual, could you please flip a coin with your right hand? So what happens if I were to ask you to flip a coin with your right hand? Well, you would understand that in Wernicke's area here, but to flip the coin with your right hand, you would need to move that information up to the motor cortex, corticospinal tract here, and you would be able to easily mimic the action of flipping a coin with your right hand, no problem. Now, but what if I ask you to flip a coin with your left hand? So again, you're understanding that in Wernicke's area, but to flip a coin with your left hand, you need to activate the motor cortex over here in the right hemisphere. And so that information moves forward and it crosses over in the anterior corpus callosum. So if you've got a lesion there, this program, the information can't get there accurately. And so the patient, when they try to mimic flipping a coin with their left hand, they really can't do it. And that is an example of an apraxia. Apraxia refers to, well, first of all, just to describe, we have hundreds and hundreds of motor programs, thousands of them, in the brain for everything we do. You know, the action of brushing your teeth, driving a car, virtually everything we do all day, we have these motor programs that can easily be pulled and executed. We don't have to think about it. Flipping a coin, there's a motor program that you've laid down for flipping a coin. And so in an apraxia, the patient has a hard time doing something, but it's not because their hand is weak or paralyzed or because they can't feel their hand or because they can't see. The problem is difficulty, either destruction of the motor program or the brain can't access the motor program, which is the case here with a lesion of the anterior portion of the corpus callosum. Okay, so there are all kinds of apraxias, a dressing apraxia where patients forget how to put their clothes on. And so if we're checking for an apraxia on exam, a good way to do that is ask a patient, show me how you would flip a coin with either hand, or show me how you would salute with either hand, show me how you would brush your teeth with either hand. These are all ways that we can assess for apraxia. And I'll give more examples of apraxia later. We tend to see this a lot in conditions like Alzheimer's dementia. All right, so again, focal left hand apraxia, where is the lesion? It's the anterior portion of the corpus callosum. All right, so finally let's talk about basal ganglia circuitry, and this will really pay off when we have our lecture on movement disorders. It really helps to understand all kinds of things, including where do you put a deep brain stimulator for Parkinson's disease? We can really only answer that if you understand basal ganglia circuitry. So remember that now this is the coronal section, so we're just looking at the posterior limb of the internal capsule here. So we have the globus pallidus, internal and external segment, the putamen, caudate nucleus, subthalamic nucleus, and the substantia nigra. All right, so here's how the basal ganglia circuitry work. So we have the motor cortex talking to the basal ganglia for movement. And when the motor cortex communicates with the basal ganglia, it talks to the striatum. Remember, the striatum is the caudate and the putamen. So all of this processing happens, and then the output from the basal ganglia is through the internal segment of the globus pallidus and a part of the substantia nigra called the pars reticulata. This is actually a non-dopamine producing part of the basal ganglia. So this projects back to the motor cortex. Okay, and remember the basal ganglia nucleus is the ventral anterior. So it goes back to the motor cortex. And I mentioned that the centromedian nucleus of the thalamus, which is important for pain, that it is also involved in this basal ganglia circuitry as well. Now we have the pars compacta of the substantia nigra. That's the dopamine producing cells. These project up to the striatum, and you'll notice that dopamine has two very different effects. It activates dopamine D1 receptors in the striatum, and it inhibits dopamine D2 receptors in the striatum. So for any of this to make sense, we need to put the neurotransmitters in. And so arbitrarily here, wherever there's glutamate, I put in 2 positive because glutamate is stimulatory, and GABA is everywhere else. And GABA is inhibitory. Yes, there's some enkephalon and substance P, but let's just stick with the GABA here. So how I remember this is if we're talking about the motor cortex, whether it's going in or going out, it's glutamate. Everywhere else, it's GABA inhibitory, except for this connection between the subthalamic nucleus and the internal segment of the globus pallidus, which is glutamate and is stimulatory. All right, so what's the function of this? Well, in terms of movement, and remember that lesions or diseases of the basal ganglia produce movement disorders. The basic rule of thumb is if we have some sort of a lesion or a process here and the net result is less glutamate going back to the motor cortex, the patient slows down and they look like they have Parkinson's disease. On the other hand, if we have some sort of a disease process or a lesion in the basal ganglia circuitry and we end up having more glutamate going back to the motor cortex, now we have a patient with an excessive movement disorder. That's called a hyperkinetic movement disorder. Okay, so the outputs here in the striatum are referred to as a direct and an indirect pathways. Direct because here when dopamine stimulates the D1 receptor, it goes directly to the output nuclei, okay, using GABA. So it tends to inhibit the GPI and the pars reticulata of the substantia nigra. Whereas the indirect pathway, there are a couple of extra steps through the external segment of the globus pallidus, the subthalamic nucleus, and then to GPI and the pars reticulata of the substantia nigra. GABA is inhibitory on the ventral anterior nucleus, and then glutamate is stimulatory. So let's give an example of this in Parkinson's disease. We've said that in Parkinson's disease, we have degeneration of the dopamine-producing cells in the substantia nigra. That's the pars compacta. So if we have less dopamine going up to the striatum, remember before there were 2 positive marks here, now there's only 1. Okay, so we stimulate D1 receptors less. That means we're going to crank out less GABA, so we have less inhibition on the internal segment of the globus pallidus. If you inhibit this less, it's going to put out more GABA, which is going to inhibit more of the ventral anterior nucleus, and it's going to put out less glutamate. Remember, less glutamate going to the motor cortex, the patient slows down, they look like they have Parkinson's disease. Okay, the same thing works through the indirect pathway. If you have less dopamine, you're going to inhibit the D1 receptor, D2 receptor less. That means it's going to put out more GABA to inhibit the external segment of the globus pallidus more. Okay, so it's going to put out less GABA, less inhibition of the subthalamic nucleus. So then it's going to put out more glutamate to stimulate the internal segment of the globus pallidus. If it stimulates it more, it's going to put out even more GABA to the ventral anterior nucleus and even further shut down glutamate going back to the motor cortex. So degeneration of the substantia nigra pars compacta, both through the direct and indirect route, both work to result in less glutamate going back to the motor cortex. And someone has Parkinson's disease. Okay, to give an example of something on the opposite end of the spectrum, let's say we have a subthalamic stroke, which I've told you produces hemiballismus on the opposite side of the body. That doesn't look anything like Parkinson's disease. They have very wild, flinging movements on one side of the body. And so if we have a stroke in the subthalamic nucleus, then less glutamate is going to go out to the internal segment of the globus pallidus. So if you stimulate this less, it's going to put out less GABA, less inhibition of the ventral anterior nucleus of the thalamus. If we inhibit this less, more glutamate going back to the motor cortex, and now the patient has an excessive involuntary movement, hemiballismus. So this really does work through to explain a lot of things in the basal ganglia, and as we'll see, there will be other clinical applications of this as well.